Good evening, ladies and gentlemen. Welcome to the third instalment of Radiology Across Borders Technologist Teleconference for 2019. My name is Luke Porra. I'm part of the Radiology Across Borders team, and it's my privilege to welcome you along this evening to this webinar on a very important topic and a very popular topic. We've got close to 250 people on the webinar this evening, and the topic, of course, is on IV contrast administration in CT. We've got a highly credentialed speaker with us this evening in Brett Edwards. So Brett has over 10 years experience in medical imaging and healthcare, recently joined Siemens Healthineers as a CT clinical application specialist. Going back a little while now, Brett qualified as a radiographer from the University of South Australia and then joined the Australian Defence Force. He gained unique experience working in the challenging army environment, particularly with trauma and in remote and rural areas of Australia and Papua New Guinea. He also worked in two of the UK's leading hospitals, being King Edward the 7th Private Hospital and the Royal Marsden Hospital as well in London. Brett's presentation this evening he'll be covering the IV contrast administration in CT, and it will include the use of IV contrast, the physiology and contrast phases, and combined with, he'll also include some practical CT scanning tips as well. So this promises to be a really valuable session. We can't go too much further without thanking our major sponsors, that being Siemens Healthineers, I-MED and Credible. And we also need to thank our webinar series sponsor, being Healthcare Imaging Services. Don't forget that at any time during the webinar, you can post a question that Brett can address at the end of the webinar. The questions, you can do that in the little console on your right-hand side of the screen. So don't be shy. Make sure you, if you do have a question, pop it in there, and we'll address it at the end if time permits. Okay, so without further ado, I'm going to hand over to Brett. Unfortunately, Brett's webcam is not working this evening. Otherwise, we'd have that up to start with. But I assure you, he's a very good-looking man. But I'll hand over to Brett now and let you get started, Brett. Thanks very much.
Perfect, thanks Luke. I'd just like to say welcome to everyone, and again thanks to Radiology Across Borders for allowing me the opportunity to present. Of course, tonight our topic is intravenous contrast, so without further ado, we'll get into it. So this is the main question: why do we actually use contrast? Intravenous or even oral contrast is used to create a temporary or artificial density difference between two objects. So ideally, our goal is to differentiate between the different tissues, which would ordinarily have similar attenuations or differing attenuations, making them more readily visible on the image. So methods of contrast administration vary widely, but in CT, enhancement falls generally under two main categories: either intravascular or gastrointestinal. Today we'll be concentrating primarily on IV contrast. So looking at the overview of what we're going to be covering tonight, we'll have a look at the what, why and how, physiology, injection parameters and scanning. Then we'll go into some questions, and we've already had some email questions around gastrointestinal contrast, so we'll address some of them as well. So at the most basic level in imaging, we use contrast to better visualize the internal structures of the body. Specifically, we use it to better visualize a patient's vessels and or specific uptake into different tissues and or regions. So looking at the properties of contrast, it's basically iodinated and is universally used for a variety of radiology examinations because they're water soluble, very easy to administer, and are very safe. So it's ionic in that it does not dissociate from ions when placed into a solution. And as I previously mentioned, iodine has a relatively high atomic number at 53. So it has a fairly high attenuation of X-rays, which makes it show up bright. It's also roughly isoosmolar with blood plasma, which means essentially the same osmotic concentration. Therefore, it doesn't exert any osmotic forces on the body. So again, anyone that's worked with contrast understands it's quite a viscous fluid, so basically thick and sticky. So obviously prior to any administration of contrast, we need to gain IV access. So usually we do that by inserting a cannula and ideally in the antecubital fossa. So prior to scanning, we then inject a bolus or volume of contrast. And the most two common methods are the hand injection or a pressure injector. So a hand injection can be used when time frames aren't too tight and is a cost-effective way to achieve contrast enhancement. Typically in Australia, we use this in post-contrast heads with 50 mils of contrast. The most common method of injection, though, is definitely a pressure or injection system. Universally, they are the standard because they can enable us to deliver precise flow rates and volumes, and the injections are consistent and can be reproduced in future examinations. So looking at cannulation in more detail, it's obviously important to select a needle size appropriate to the type of enhancement we wish to achieve. When we're choosing a vein, we want to choose a large vein that has low resistance and enables flow rates with low pressures. So when we decide the needle, there's also the intermediate tubing that is often overlooked. However, if you're using a large needle with a thin tube, it's effectively the same as just using a thin needle. So we need to consider the tubing. The wider the tubing, the lower the pressures will be. So we've already briefly spoken about one of the properties of contrast in its viscosity. Typically, we want to raise the temperature of the contrast roughly to body temperature. This enables easy flow and reduces the potential for a reaction. So just to put that in context, if we leave a 100 ml bottle of contrast on a bench for an hour, it's dropped approximately 50% already. Obviously, we cannot control our patients. It's important to work around our patients. Ideally, we would always like to inject into the antecubital fossa. However, this is not always the case, and in some instances, we need to look elsewhere. Some of these scenarios include an inability to find a vein, brachial lymphectomy, and edema. In these cases, I would look to the other arm or more peripheral access. We could potentially use a reduced flow rate and/or a test injection of saline to test its patency, and/or use a test bolus to more specifically determine the scan delay required. As contrast media is a form of medication, and obviously it's a foreign entity to the body, there's always a potential for a reaction just like any other medication. So there's a range of potential reactions that people can experience, from welts, rashes, hot sensations, to the metallic taste we all talk about, to more serious reactions at the bottom of this list. So we're briefly going to talk about contrast reactions. So there are two major classes of contrast reactions. We've first of all got dose dependent, which are predictable in nature, and they can be further broken down into two categories of osmotoxicity and nephrotoxicity. So we've already sort of talked about isoosmolar in that if we've got something similar concentrations to blood plasma, it won't exert an osmotic force on the body. So, however, we can get close to isoosmolar to blood plasma. We can't ever truly achieve it. So it still does have an osmotic effect. So if we inject a large volume, it will still exert a force. So we need to be aware of the amount of contrast that we're injecting. Same goes with nephrotoxicity, so it's just toxicity to the kidneys, and it adversely affects renal function. So another class of reaction is idiosyncratic or unpredictable. So these don't depend on dose or concentration. They include hypersensitivity reactions, which are just basically undesirable reactions produced by normal immune system. These are much like allergies or hay fever that people get. So then we start looking at some more serious reactions. So anaphylactic reactions, so any serious allergic reaction, it's rapid in onset and can potentially result in death. Typically it starts as an itchy rash and throat or tongue swelling, shortness of breath, vomiting, lightheadedness, and low blood pressure. Then we have a third type, anaphylactoid, which essentially produce the same clinical picture as anaphylaxis, but occur through a non-immune mediated pathway. They can be vomiting, So I've also included the RANSCAR reaction classifications. This is probably more what radiographers are inclined to understand them as, so mild, moderate, and severe. This is pitched at radiologists in terms of treating the actual signs and symptoms. I won't run through the whole thing, but I just wanted you guys to have it for future reference. So looking at some statistics. So of the total number of people that were injected, 3.1% of people had a reaction, and of those, 0.04% were considered severe reactions, and of people that had a prior reaction, there was 11%. So some other interesting points that the study made were that severe reactions were most common in the age 20 to 29 group, followed by the ages 30 to 39 and 10 to 19. Also, it was rarer after the age of 50. Further interesting points were 48.7% of all reactions occurred during the injection, 21.6% within 5 minutes, and 15% after 5 minutes. Finally, I will just say one thing. There was no clear relationship between the amount or dose and the incidence of severe reactions. So far, we've discussed immediate reactions, but we can also get delayed reactions. They're generally hypersensitive in nature. Delayed hypersensitive reactions are inflammatory reactions initiated by a secondary cellular response. So therefore, they appear 48 to 78 hours after the antigen exposure. The literature varies, but typically occurs between 2 to 10% of patients. So we've already spoken about warming up contrast to reduce the viscosity of the material. It also reduces the risk of an adverse reaction to the contrast. By warming up the contrast, we can reduce the potential for an anaphylactoid reaction by 2%. And as such, it's become the gold standard in many imaging departments around the world. There are considered patient risk groups and typically related to organ systems shown here. As such, we typically use a patient questionnaire to check for allergic reaction, renal and medical risk factors. Again, I've included the RANSCAR version for your future reference. We won't spend too much time on it. So once the contrast is injected, it obviously systemically flows around the body. So if we think about where it's injected, it'll then enter the subclavian vein into the superior vena cava. It'll then head into the right atrium, into the right ventricle, into the pulmonary arteries, back through the pulmonary veins to the left side of the heart, left atrium, into the left ventricle, and back out to the aorta. Once it's in the aorta, it'll go up the carotid arteries to the head and down the aorta to the rest of the torso and legs. So in saying that, it's a good idea to have an understanding of rough timeframes of where contrast will be at what time. So main pulmonary artery, 9 to 15 seconds. In the aorta, from 15 to 22 seconds. The carotid, 16 to 24. Femoral arteries, 22 to 33. So contrast phase terminology does vary. It varies a lot between sites, between radiologists, within the practice, what a doctor considers. So it's really important to clarify exactly what the referring doctor means, what the radiologist means, so we can get specific on timings and everyone's on the same page. So like it says down the bottom there, the various terms, they generally change quite a lot between each of them, but these are some general terms that are sort of common practice and everyone sort of is in agreement. So we're going to start looking at the injection parameters and considerations. There's quite a lot of graphs coming up, so we'll go through them and we'll get through them hopefully fairly quickly. So if we look at injection rate, obviously, if we trickle in at one millisecond, the enhancement never really reaches a true peak enhancement. It just slowly infuses into the body and into the organs. As we then increase the rate of injection, we start getting some real enhancement in the aorta. We can also sort of see the secondary hump of basically each of the contrast lines in which the contrast is starting to be recircled through the body. So then same thing on volume. If we have a really small injection, we have less of a peak enhancement and it's shorter lived. So when we look at concentration, we haven't talked much about this. We can get different iodine concentrations within our IV contrast. Typically, we'll use 300 milligrams per litre per mil, and for our routine scanning, and we'll use say 350 for our angio-based scanning. But again, obviously, if we have more iodine in the contrast, it will be brighter. So again, saline flush, it's a great way to maintain the push of the bolus through the scan. It also increases peak enhancement because it basically continues that push. It also can potentially reduce the volume of contrast we require for the scan. So when we start looking at patient styles, we start looking at the physics and obviously a bigger patient, there's going to be more general attenuation, so there's going to be less aortic enhancement. Same goes the opposite way. If you're to go to a smaller patient, you're going to have less attenuation, so the iodine's going to attenuate it more. So cardiac output is another important thing to consider. So if you've got a really old patient and have a really poor cardiac output, all the timings that we discussed, or the phases, will be pushed out, and vice versa. Another really important one is KV settings, and sometimes we're limited by our system in terms of what KV we can even choose. Certainly, the next couple of examples I'm going to show you will sort of be the extremes of what some systems can achieve. But essentially, if we use a lower KV, we'll have an increase in contrast resolution. And potentially, if we go to a higher KV, we can actually hide the fact that contrast is even existing. So I've got some examples here. So this patient, or this abdomen pelvis, was scanned at 70 kV with only 70 mils of contrast, and it's basically undiagnostic in the sense that their kidneys are lit up like a Christmas tree. Then we go to the other end of the spectrum. This was scanned on 130 kV with 100 mils of contrast, and it's barely even noticeable that we have any contrast in there. They were 168 kilos though, so. So if we start moving on to some scanning now, we've got a lot of different options for us. So essentially, and historically, I suppose, we would always do a fixed delay, and say, okay, we're going to have a delay of 30 seconds for a chest, and that's when we're going to scan it, and we know that's roughly when arterial phase is, so that's how we're going to do it. Then we started bolus tracking. So essentially, that is running a pre-monitoring slice or a localizing slice, and then setting a region of interest, and then starting the injection, starting the scan, and then look at the monitoring slice. Once it reaches a certain Hounsfield unit, it will trigger, and then we'll complete the scan. And it's a more accurate way to say that we're capturing either an arterial phase or a certain phase. Then we look at test bolus. So we actually do a small test injection of contrast, and we scan and we watch the contrast flow in and out. At a certain point, we can then more accurately know when we need to scan. Then we can do a second injection with our set delay, and then scan through that injection. So in the last two examples I used, and we needed to set a ROI. So when we set a ROI, or a region of interest, we need to consider a few things. So we want to make it large, but not so large that it includes more than the vessel. We want to make sure that it includes enough data so that if there is a deviation within the Hounsfield units, that it doesn't cause it to automatically trigger off of a false positive or not reach a point of triggering. So when we look at bolus tracking, so we're going to do the pre-monitoring slice, then start monitoring with the injection, and then once we reach the peak, it triggers and we scan. It's probably the most common way to monitor contrast and scan. It is also potentially quicker because we're only doing one injection and then one scan. It's also probably most tech's preference, or the most well-known. So looking at test bolus, there are some significant advantages of using this, but it is a little bit more complicated, so people don't tend to use it. So it enables us to check the cannula before we actually do the scan. So it's also potentially more precise in our scan times and when we want to be scanning. We don't have any risk of potentially triggering too early because we misplaced the ROI or too late. It also allows us to check for an allergy to the contrast. It also could enable us to see what their heart rate does once they actually receive some of the contrast. So we'll start running through some routine scanning protocols. So not angiograms, but just standard routine scanning. So we'll cover chest with contrast, just portal venous, abdomen, pelvis, and a multi-phase liver, primarily because it covers a few different phases and a few different techniques. So chest with contrast, looking at some of the clinical indications, pneumonia, pleural effusion, mass, oncology, list goes on and on. Essentially, we're going to just scan above lung apices to below the adrenal glands or somewhere thereof, dependent on your local protocol. The actual scan technique itself, we generally have the patient supine, feet first, arms extended above the head, or potentially resting on the gantry. So during the scan itself, obviously we'll have an inspiration. Hopefully they can hold their breaths well. So with the IV contrast, generally speaking, most sites will give 75 mils of contrast and aim for 3 mils a second. Obviously, these are the ideal circumstances. Not everyone can receive 3 mils a second. So ideally, we're timing for an arterial phase, and generally speaking, best practice is to bolus track, so monitor the aortic arch, and basically once we reach an auto trigger of 100 Hounsfield units, we'll then start the scan. The machine will then move back above the lung apices and scan through the lungs. So what we're looking here is, this is just a DICOM viewer, and I've just basically arranged it in scan order. So we've got the topogram that we've performed here, and then we've got our pre-monitoring slice. This yellow box corresponds to this yellow line. Once we've done the pre-monitoring, we can set our ROI, which we've set in the aorta here, and then it then gets to a point, and this is the triggered slice. So this was the last slice it took before scanning through. We have our thin data set here, thin data set of lung window and lung kernel, and then we've got our 3 mil slices at the end here. So moving on to the portal venous abdo-pelvis. So again, clinical indications are hundreds of different things, but we can have query diverticulitis, collection, appendicitis, bowel obstruction, perforation, abdo pain, loss of appetite. So essentially for the scan range, we're going to scan from above diaphragm to below pubic symph. Again, scan technique, patient supine, arms extended above head, breathing instructions, suspended full inspiration again. Now, a lot of sites won't do this. Best practice would be to give them 3 cups of water just prior to the scan to fill the stomach with water. Very few practices would do it, but it is definitely best practice. Now, with the contrast, generally speaking, we're looking for 100 mils at 3 mils a second. and timing. So again, most sites probably use a standard set delay of 70 seconds. My personal favorite is actually bolus tracking, monitoring off the aorta. Once it triggers at 100 Hounsfield units, then use a 45-second delay. So that just basically enables, or it takes into consideration the cardiac output of the patient and achieves a more true portal venous abdomen pelvis. So again, looking at this one, we've got monitoring slice here, we've got the pre-monitoring slice, we have the triggered slice, and then we have our resultant scan. So we want the aorta and the IVC to be roughly the same. That's another way that you could do it. You could just eyeball it, and when they look exactly the same, you could scan them. So looking at the multi-phase liver, looking at some clinical indication, we could have abnormal liver function test, hemangioma, metastases, and the list goes on. So looking at the scan technique again, patient supine, arms above head, suspended full inspiration. IV contrast, we're going to go for 100 mils at 3 to 4 mils a second. And when we start looking at the timing, so we want to achieve a arterial phase generally, portal venous, and delayed. And in some circumstances, we'll also do a non-contrast. So for the arterial phase, this particular protocol is using bolus tracking, and we're going to monitor off the aorta. We're going to start monitoring after 15 seconds because generally it'll take around 15 seconds for contrast to get there. We'll trigger at 100 Hounsfield units and then scan immediately. Then so after that scan is finished, we'll then add an interscan delay of 35 seconds, and then it will scan the whole abdomen pelvis in true portal venous phase, hopefully. Then if we see a hemangioma, we can do a delayed phase at say 8 to 10 minutes. And generally speaking, what we'd do there is just have a look at the contrast conjecture or just look at the time and then just scan. So we've got here the non-contrast abdomen. We've then got the arterial, portal venous, and delayed. So this is essentially the same thing, just a slice a little lower. All right, so we'll move on to some angiogram scanning protocols now. So we'll cover off on the cow, carotid, aorta, and pulmonary angiogram. So looking at the cow, clinical indications can be aneurysm, headaches, etc. Scan technique, generally we're going to be head first this time. We're going to perform a non-contrast head prior, and then we're going to move into the contrast. So we're going to look at 75 mils of contrast at 4.5 mils a second. Generally, we're going to monitor it or bolus track at base of skull, and we're going to have a look at the first flash of contrast in the internal carotids. We're going to start the scan and hopefully get images like that. So looking at the carotids, so clinical indications could be stenosis, dissection, etc. We're going to scan below aortic arch to above the circle of Willis. So scan technique, we're going to be scanning supine head first. Generally, I won't give any breathing instruction, but you can. And we're going to scan inferior to superior. Some sites I know will scan superior to inferior to reduce venous contamination. And we're going to go 100 mils a second at 4.5 mils again. So this time we're going to monitor on the arch and trigger off the arch at 100 Hounsfield units. So aorta, I'm just going to generally talk about this. Often people will break it down to thoracic and abdominal. Generally, we're looking for either aneurysms or dissections. We're going to scan above the arch to below aortic bifurcation. So again, supine, arms above head. We're going to have a suspended full inspiration. We're going to go 100 mils of contrast at 4.5 mils a second. Now, potentially 125 mils for slower scanners. And if you're not sure, 125 mils might just be a safer option. So again, we're going to bolus track. So we're going to monitor off the aortic arch. Once it reaches 100 Hounsfield units, we're then going to scan down, hopefully following the contrast. So here's another example. We've got our topogram, we've got our pre-monitoring, and then our monitoring. It's triggered off of the aorta, and then we've scanned down. So looking at the CTPA, so this is primarily done for a pulmonary embolus. It can be done for a raised D-dimer or sudden onset unexplained shortness of breath. So we're going to scan again above lung apices to below the costophrenic angles. So we're going to go supine, arms above head again. Breathing instructions really important for this one so they don't valsalva. Generally, we either want a gentle suspended inspiration or a stop breathing. I prefer the stop breathing. It's really important to explain this to the patient. So when we actually do the scan, we're looking at 75 mils of contrast. We're going to go at 4 mils a second. So there's two potential methods that we can use for this. Bolus tracking, which is the one that we've covered off on quite a bit so far, which is the pre-monitoring and then monitoring trigger. Now, a lot of places will also do this using a test bolus. So they'll do a 20 mil injection of contrast. They'll then have a look at it coming in through the pulmonary trunk. The system will decide what's peak Hounsfield unit and the time to peak. And then they will set that as the scan delay, inject 80 mils, and then scan at that set delay. So using bolus tracking, we've set the ROI in the pulmonary trunk, and you can either trigger it before or you can let it trigger at 100 and then it will scan. When we use the test bolus method, we do a small injection first of 20 mils or so, and then we basically monitor it, watch it come in. We need 2 slices before, 2 slices after what we consider the peak, and then we can suspend, and then we can load it into Dyneema. That's this. We then use this tool here to set the ROI, and it will then tell us the time to peak enhancement. it's really important to have the actual delay to the monitoring to be input here. Otherwise, the timings will be incorrect. So that basically concludes the presentation. I'm going to roll straight into some questions that I've already had emailed to me. They're in regards to gastrointestinal contrast. So first of all, using oral contrast is becoming far less frequent in Australia. From my clinical experience and understanding, positive and negative contrasts have a similar diagnosis rates. Therefore, the trend is towards the use of negative oral contrast because it's safer. And in saying that, it also often ends up being the reporting doctor's preference, as the clinical responsibility lies with them. That was in response to number one. Number two, so the only time I've ever used positive oral contrast in a rectal protocol was a complex case looking at a rectal fistula. I would probably consider saline to be a negative contrast as relative to the gastrointestinal tract wall. It holds a lower Hounsfield unit. So I don't either know the clear reason, unfortunately. So looking at all of these, in regards to the protocols for oral contrast and clinical indications displayed, these vary greatly between sites, and again, it comes down to the doctor's preference purely because it's their clinical responsibility to make the call off of the images. So I hope that sort of answers your questions. So I suppose we'll open up to the floor now, and anyone can go ahead and ask some questions.
Thanks, Brett. Yeah, that's been fantastic, and a reflection of that is the number of questions we've got from a number of people. I might just roll through a few of them with you.
Yep.
Probably the first one is from Kong Hung, who has asked, what's your preferred method of tracking? Is it bolus tracking or test bolus tracking? And what's the accuracy between the two in terms of timing?
Good question. So I suppose it depends on the clinical indication, but generally speaking, I'm a big fan of test bolus. It enables us to be far more accurate. So say, for instance, if we take CTPA for an example, we can use a test bolus, we can see the contrast come in through the pulmonary trunk, and then we can actually see it come to the aorta. So we then know when we want to basically have the scan finished. So we don't want any contrast in the aorta, and we can then scan through, make sure the scan's finished before there is contrast in the aorta. Also with cardiac scanning, we can be far more accurate using test bolus. However, I'm still a massive fan of monitoring as well. It's by far the most commonly used. Pretty well everywhere I go, I'm trying to convince people to use test bolus. But there's no right or wrong way. You can get good results using both.
So I guess if people were interested in using test bolus, it'd be particularly pertinent to use with the cardiac, or try using with the cardiac scans and the pulmonary.
Yeah, like the CTPA is generally a really good place to start using test bolus. But certainly if you're new to scanning CTPAs, I would definitely start with monitoring.
Okay. That probably brings us to our next question from Imran. Now, Imran's asked, what will happen if a patient performs Valsalva during a CTPA?
So generally you have you won't have contrast in the pulmonary trunk. You'll have contrast in the aorta and pretty well everywhere else, except for the pulmonary trunk. There's a few other techniques you can use to try and get them to not Valsalva. Really, patient prep is the key on this one. Just explaining to them the need for them to stay calm and just have regular breathing. You can also get them to try and breathe through their nose instead, and or keep their mouth open, because it's incredibly difficult to Valsalva when your mouth is open.
Okay, we have another question from Sandra, and this one is, why do we pick 100 Hounsfield units? I think Sandra is saying that they tend to use 150 Hounsfield units in their practice.
Yep. So it depends how the system is doing it. So I know Siemens. So I'm talking from like a Siemens perspective here. Essentially, they will use a baseline off the pre-monitoring, and then it will be 100 Hounsfield units on top of that. So it's not a true Hounsfield unit. So if you say, for instance, say the aorta might have a base Hounsfield unit of 50, when I say 100, it is 150. That's a very good question and a good point to clear up. So depending on your scanner, it may not use a baseline. So I certainly know GE don't use a baseline. So it's just true 150 Hounsfield units, which may be the case in that scenario. The other one is it's a way to control the phase timing. So if your doctor says that everything is too early, you can increase the Hounsfield units to basically push out that timing. It's probably not a way that I would suggest doing, because you can change other things before changing the trigger.
Okay. We've got a question from Peter, and the question is, in regards to, you made some comments around clarifying around KV settings, and when you lower the KV, will there be an increase in tissue differentiation? Would you just mind just clarifying that?
Yeah, so essentially at a lower KV, we have an increase in contrast resolution. So when we're doing contrast studies, it is desirable to have a lower KV. However, it is sometimes difficult dependent on the system and the tube output, because obviously if you lower the KV, you need to increase the MAS to maintain the same image quality. So it becomes difficult in that regard. Sometimes, or in most scenarios, we're sort of locked out by the system's capability, so we don't have true choice over the amount of KVs or that it wants to give. Do you want to just repeat another part of that question? I've just missed part of it, I think.
Yeah, so Peter was just asking you to clarify, around the KV settings, and that you lowering the KV will increase the tissue differentiation.
Yes, well, it'll certainly increase contrast resolution. And then the flow on of that is tissue differentiation.
Okay. Just changing the topic slightly, Ian sent in a question, and this one may be a little tricky to answer, and it does depend on the radiologist, of course, but is 30 still the lowest eGFR we are allowed to give contrast, and should we still pre-hydrate for 2 hours and then also post-hydrate as well for eGFR below 30?
Yeah, so certainly pre and pre and post hydration is a good idea, purely because it will just basically flush the kidneys of contrast, and it will just encourage the process of moving it forward. Again, the EGFR below 30 generally is sort of the unspoken rule that I follow. It certainly depends on your particular policy at the hospital. I think the RANSCAR guidelines are also in line with that. They wouldn't recommend giving contrast to an EGFR below 30.
Just on the RANSCAR guidelines, you made reference to a few times as a resource. Just for those that don't know, RANSCAR is the Australian New Zealand College of Radiologists, and there's heaps of good guidelines and information on their website. So if you are looking for some guidelines, then please just Google RANSCAR, which is RANZCR, and then have a look at their site, because there are lots of guidelines on there. And you recommended a few there too, Brett, including an example of the questionnaire for contrast media as well,
yeah.
which is really good as a baseline. Okay, there's we'll probably answer just perhaps 2 or 3 more. Okay, so Georgia Taylor has asked, when you mentioned you can change other settings before changing the Hounsfield unit trigger for a CTPA, what would you suggest changing before changing that Hounsfield unit trigger?
So again, it depends on what system you're on, but if you've got like a post-bolus delay or a post-trigger delay that you can control, I would change that, because essentially if you look at, say for instance, we're monitoring every 1 second or 1.5 seconds, the contrast, the rate at which the contrast enhancement is moving is really quick. So the trigger from say 100 to 150 may only be like 1 second difference. So if the doctor's complaining that it's like too early all the time, you're better off basically pushing out the scan itself using that time.
Okay, and another question here is around how long you leave a patient on the table post-injection to observe any delayed reactions. But Peter's just asked for a bit of a guide around that.
Yeah, okay, so like from my clinical experience, the rough guide is if they have no sort of risk factors of having a reaction, they leave the cannula in for 15 minutes. It's not on the table, but it's basically in like a sub-waiting area. And then if they do have risk factors suggestive of a reaction, it would then be half an hour and then the cannulation would be removed. But beyond that point, it basically is assumed that they're not going to have a serious reaction.
And on the topic of delays, with the liver scan, why the 10-minute delayed phase if you've seen a hemangioma? What effect are you looking for in that?
You want to see if there's blood pooling within the mass, essentially.
So essentially there would still be contrast in that hemangioma at 10 minutes?
Potentially, yes.
Okay. All right. Well, we've hit 8 o'clock, so I probably will wrap up there. There are heaps more questions there, and I'd like to thank everyone for sending their questions in. Really important topic, and I'd like to thank you, Brett, for the work you've done putting that together. We need to thank our major sponsors, being Siemens Healthineers, I-MED Radiology Network, and Credible, and also our webinar series sponsor as well, Healthcare Imaging Services. Please remember that all of our webinars are recorded and can be accessed via the Radiology Across Borders website, which is www.radiologycrossborders.org. And you can also sign up for our newsletter through the website, and that way you'll always be kept up to date with the work going on. Everyone who has attended this webinar will receive an attendance certificate with an email in about 24 hours or so. Our next webinar is also on a CT topic. It's on trauma CT, and Victoria Bailey will be hosting and presenting on that one. So keep an eye out for an email in the very near future with information on how to register for the trauma CT webinar. Thanks again, Brett, for your work, and I hope that everyone that was listening in this evening got plenty out of that. I'm sure they did, and I'll probably. Have you got anything more to say, Brett?
Just thanks everyone for spending the time to listen, and hopefully you got something out of it. Thanks, Luke, for hosting it tonight. That's all. Everyone, enjoy.
No worries. Well, thanks again for everyone joining us, and I'll sign off now. Thank you.
Thanks, everyone.